Hello everybody, Dr. Gavin Gardner here with another short video where I take a medical topic and peel it back like an onion, exposing all the layers, but no tears. Ice cream truly is one of mankind's greatest inventions, and this ice-cold summertime treat comes in multiple flavors. Despite all the wonderful flavors of ice cream, most of us still pick chocolate or vanilla, chocolate making up 17% of all the ice cream ordered, and vanilla making up 15%. Like ice cream, Epistaxis comes in multiple flavors, but 90% of what we see in the ER comes in one of two flavors. Your nose isn't bleeding anymore, but thanks for coming. Or, holy shipwreck, it won't stop bleeding. Both of these patients come with their own challenges. How do I satisfy the patient whose nose isn't bleeding anymore, but they still want me to do something about it? And how do I keep the other patient from exsanguinating from their nasal hemorrhage? For the patient whose nose isn't bleeding anymore, I can teach them about epistaxis prevention and how to treat their nosebleed at home. For instance, avoidance of digital trauma, aka digging for gold, aka nose picking. Also, I can teach them about using nasal saline. If they do get a nosebleed at home, they can be instructed to use Afrin. Its vasoconstrictive action can be a good adjunct to the primary treatment, which is holding pressure on the soft tip of the nose for 15 to 20 minutes continuously. What happens so often is they'll hold pressure for 30 seconds and then they check, still bleeding, so they hold pressure for another 30 to 45 seconds, still bleeding. They have to hold it continuously for 15 to 20 minutes. Before we talk about treating active epistaxis, let's go briefly over some of the pathophysiology, starting with risk factors. Number one on the list is digital trauma. We kind of talked about this already, but this is when Mr. Thumbkin goes looking for the boogeyman in the Batcave. Other risk factors include rhinosinusitis, the use of anticoagulation, trauma, cancer, dry mucous membranes. Hypertension is on the list and is somewhat controversial. It's thought most likely that hypertension propagates an ongoing episode of epistaxis, but is not necessarily the cause of epistaxis. And then last on the list is Osler-Weber-Rendu syndrome, or hereditary hemorrhagic telangiectasia, which is certainly a mouthful. Staying with the ice cream theme, there are two different flavors of active epistaxis as well: anterior nosebleeds and posterior nosebleeds. Anterior obviously making up the majority of what we see. The bleeding from an anterior nosebleed comes typically from Kesselbach's plexus, which is usually visible using a bedside nasal speculum. On the other hand, posterior nosebleeds come from Woodruff's plexus, which is not visible typically using a bedside nasal speculum. You might read that blood in the posterior pharynx is indicative of a posterior nosebleed. However, I've seen plenty of anterior nosebleeds with blood in the posterior pharynx. A fairly reliable physical exam finding for a posterior nosebleed is that they're bleeding from both nares. If they're just bleeding from one nare, it's more likely to be an anterior nosebleed. All right, enough about anatomy and physiology. Let's get down to the meat and potatoes and start talking about how to treat a nosebleed, starting with equipment. It should go without saying that we're going to need suction. A nasal speculum is nice too, so we can kind of see what we're working with. Bayonet forceps are nice, but any kind of forceps will work just fine. Maybe an emesis bag or a basin. A headlamp is nice to have for a little extra lighting, along with some gauze. Some type of vasoconstrictive spray like Afrin, and then maybe some silver nitrate in case we see a little bleeder that we can cauterize. Some tamponade device like a Maricel pack or a Rhino rocket. Maybe a thrombogenic foam like Surgicel or gel foam or Flow Seal, and then a biohazard bag to put everything in. Now, you don't necessarily need all of these things, but this is a complete list of everything that you might use for an active episode of epistaxis. So, what about blood pressure control? Really, it correlates poorly with the amount of bleeding unless it's an arterial bleed. But for sure, it's going to be one of the first things the ear, nose, and throat doctor asks you about when you get them on the phone. If we do decide to treat the blood pressure, it doesn't mean we're going to put them on a nitro drip. It might be as simple as a little anxiolysis with a benzodiazepine. Okay, everybody that likes algorithms, this is your slide. This is a step-by-step approach to active epistaxis. Step number 1, evacuate. And I don't mean clear out the emergency department. When I say evacuate, I mean have them blow their nose. That gets rid of all the clots and gives us a clear look at what's going on inside their nair. Also, it gives us a surface to apply our medications to. Then we can spray Afrin into the affected nair, or nares, or plural of nair, and then we can apply direct pressure. Remember, this is unrelenting pressure for 15 to 20 minutes. No peeking, just like we talked about before. So we've had the patient holding pressure for 15 minutes, and we take a look. There's still a small area of bleeding that we think that we can cauterize using silver nitrate. We can anesthetize the area by soaking a cotton ball in Afrin and lidocaine and leaving that in place for a few minutes. We have to be cautious with the silver nitrate. We're not trying to paint the whole septum with it, just a few seconds of contact over the area of bleeding. If that few seconds of contact doesn't work, move on to something else because the silver nitrate just isn't going to cut it. It's also worth mentioning that we shouldn't cauterize both sides of the septum because we risk perforation. If, after 15 minutes, we take a look and there's still a lot of bleeding, well, it's time to pack. The type of packing device that you use depends on what you have available in your emergency department. We can lubricate that device with a little bacitracin and apply either some Afrin or even better TXA or maybe even both. Remember what the nasal anatomy looks like. You don't want to insert the device upwards like you might think. It's going to go straight back, almost like you're pointing it towards the occiput. Whatever device you use, make sure that you insert it all the way. Now your patient's not going to like this, and you might learn a few new words, but don't leave it hanging halfway out their nair. The number of devices that you have to choose from are almost as numerous as Genghis Khan's children, but we're just going to go over some of the more popular ones. Maricel is probably the most commonly seen nasal packing device out there, but it certainly isn't my favorite. It's like shoving a popsicle stick into someone's nose. The picture does show the proper angle for insertion as well as what it should look like after it's inserted. Once it is inserted, it begins to swell and it'll apply pressure to the bleeding area. You can also apply TXA or Afrin directly to the Maricel. The Rapid Rhino is an inflatable device that seems to be tolerated by patients a little bit better. Soaking it in water activates the lubrication on the outside of the device, and its diameter is smaller so it's easier to insert. Once it's inserted, it's inflated with air, providing the tamponade necessary to achieve hemostasis. If that doesn't work, you and your patient are both going to be praying for some relief. Because if medieval kings had known about nasal packing, we may have never seen the likes of the rack or the Iron Maiden. At this point, your patient's going to need some reassurance and perhaps some anxiolysis as well as some pain control. Because now, we're going to pack both nairs using the same techniques as described previously. Okay, apparently you hate puppies and peaceful tranquility because your patient's nose is still bleeding. Now, we're going to place a device used for a posterior nosebleed. Devices designed and manufactured for posterior nosebleeds come with two balloons, a distal balloon and a proximal balloon. If one of these specific devices isn't available, you can consider using a Foley catheter, but the Foley catheter must be used in conjunction with anterior packing or some way to affix it so that it applies pressure to the posterior bleed. The device is inserted and then the distal balloon is inflated. Then you pull back on the device until resistance is met. At that point, you inflate the proximal balloon until hemostasis is achieved. No up-to-date discussion about epistaxis would be complete unless we at least discuss TXA or tranexamic acid. TXA is a synthetic analog of the amino acid lysine and really has been a game changer in the way that we treat epistaxis. We found a lot of other uses for TXA as well, and it's even used in the treatment of hereditary angioedema. It can really be used at any stage of the treatment algorithm, and we've seen a lot of success when we use TXA as part of our strategy. Okay, to wrap everything up, let's talk briefly about disposition. So all patients who get packing should be observed in the emergency department for at least an hour to make sure that there aren't any complications. They should obviously have close follow-up with an ear, nose, and throat physician, but if there's any concern, we just put them in the hospital for observation. All patients with posterior packing should be admitted to the telemetry floor with ear, nose, and throat consultation. And universally, ear, nose, and throat physicians are going to recommend antibiotic prophylaxis. Usually this is augmentin or clindamycin in the penicillin allergic patient. And now you know all about epistaxis. There should nary be a time when you don't know what to do. I hope that you found this short video useful, and it was my pleasure bringing you this educational material.